Good morning. Good morning. It's a pleasure to have this committee hearing here today. This is a committee of Council on People with Disabilities and Special Needs, and we will begin by letting people know that under state law currently requires that the following announcement be made at the beginning of every remote public hearing of council as follows. Due to the current public health emergency, City Council committees are currently meeting remotely. We are using Microsoft Teams to make these remote hearings possible. Instructions for how the public may view and offer public testimony at public hearings of council committees are included in the public hearing notices that are published in the Daily News, Inquirer, and Legal Intelligencer. Prior to the hearings, and also can be found on phlcouncil.com. I will note that the hour has come for the beginning of this hearing. Mr. Iannuzzi, will you please call the roll to take attendance? Members that are in attendance, will you please indicate that you are present when your name is called? Also, please say a few brief words or paragraphs, depending on your decision today, when responding, so that your image will be displayed on screen when you speak.
Councilmember Cindy Bass.
Good morning, Mr. Chairman and colleagues and viewing public. I could go on and say a few paragraphs, but I think I'll stop there, Mr. Chairman.
Thank you.
Thank you.
Councilmember Jamie Gauthier.
Good morning, Chair and colleagues. Happy to be here today.
Good morning.
Councilmember Catherine Gilmore Richardson.
Good morning, Mr. Chair. Good morning, colleagues. Happy to be here. Thank you so much.
Councilmember Helen Gim.
Good morning, Council Chair, and good morning to my colleagues.
Councilmember Isiah Thomas.
Present.
And Chair Derek Green.
I am present. I'm going to call this public hearing of the Committee on People with Disabilities and Special Needs to order. A quorum of this committee is present, and this is a hearing regarding resolution number 200527. Mr. Iannuzzi, will you please read the title of the resolution?
Resolution number 200527, resolution authorizing the Committee on People with Disabilities and Special Needs to hold hearings regarding the consequences of potential additional cuts by the Commonwealth of Pennsylvania General Assembly to mental health services, especially those offered in the city of Philadelphia.
Thank you, Mr. Iannuzzi. Before we begin to hear testimony from the witnesses we have here for today, everyone who has been invited to this public meeting that's going to testify should be aware that this hearing is being recorded. Because the hearing is public, participants and viewers have no reasonable expectation of privacy. By continuing to be in the meeting, you are consenting to being recorded. Additionally, and prior to recognizing members for any questions or comments they may have for any of our witnesses today, I will note for the record at this time that we will use the chat feature that's available in Microsoft Teams to allow members to signify that they wish to be recognized. In order to comply with the Sunshine Act, the chat feature must only be used for this purpose. So please, only members of council provide notes in the chat feature. Before we call for the first panel, I want to thank everyone that's here to testify and are viewing this hearing. This is a very important issue in so many ways. We all know the deep impact that the pandemic has had on everyone throughout the city of Philadelphia and around the world. For those that have a learning or physical difference, this issue has been so much more acute. And so people have been disrupted in their normal operations, their additional supports they've had, and they've really had to adapt based on this pandemic. the agencies that are represented today and a number of agencies around the city of Philadelphia and around the region have really strived to provide services to this population. But my concern is what will happen if additional resources are cut. Some of you on this panel and some of my members may recall that when we had the Great Recession, there was a significant cut to the budget for these services that helped some of the individuals who have learning or special needs. In particular, during the Corbyn administration, we saw a cut of about $84 million that occurred from the budget, and those dollars were not replaced. Now, that time period when we had the Great Recession, we had a deficit at the Commonwealth level of close to about $700 million. Going into next year, it's anticipated that the Commonwealth will have a deficit close to about $4 billion. So the concern is what will happen if we have that type of deficit, and how will the Commonwealth adapt in making cuts? We've seen how cuts were made in the past, which had a disproportionate impact on this population. And my concern is as we go into the next year, and as we as a council go into our next fiscal year from a budgeting perspective, how will we make up the difference? Traditionally, the city has budgeted from a perspective that whatever grant dollars we receive from either the federal government or the state government, those are the dollars that we use for the provision of those services. So if there is a scenario where significant cuts occur, that could have a very decimating impact on this community. And so from my perspective, having this hearing was a great way to start this conversation and put this on front of mind, not only for the city administration, but also members of council, that as we go into our budgeting process, starting in the beginning of next year, that we have an understanding what type of impact state budget cuts may have to this population. So that's why I think it's very important to talk about this conversation, especially in context of the COVID epidemic and pandemic that has impacted so many, but especially this population of people that have a physical or learning difference. And with that, Mr. Iannuzzi, if you can call the first panel of witnesses that we have here to testify this morning.
Dr. Jill Bowen, Acting Commissioner of the Department of Behavioral Health and Intellectual Disability Services.
Good morning.
Good morning, good morning, good morning. I'll give you a few moments because I know you were coming on right around this time. So I want to thank you for being here. Also, I would like to thank your work coming in as the Acting Commission for the Department of Behavioral Health and Intellectual Disabilities. And also, I have to commend the work of your staff, Nicole McConnell, as well as the outgoing Commissioner, Commissioner David Jones, for the work that you all have done as an agency in trying to continue to provide guidance and services for individuals that have been dealing with some of the issues we're talking about today. I hope you're now connected and ready to proceed. And Dr. Bowen, if you could state your name for the record and then proceed with your testimony.
Dr. Jill Bowen, Acting Commissioner, Department of Behavioral Health and Intellectual Disability Services. Good morning, Chairperson Derek Green, Vice Chairperson Helen Gim, and members of the Committee on People with Disabilities and Special Needs. I am Dr. Jill Bowen, Acting Commissioner of the Department of Behavioral Health and Intellectual Disability Services, DBH IDS. Thank you for this opportunity to testify in response to resolution number 200527. DBH IDS is responsible for oversight of a provider network that funds services for children, youth, adults, and families in Philadelphia with behavioral health challenges and/or intellectual disabilities. Much of this work occurs throughout 3 of the 6 divisions that comprise DBH IDS: Intellectual Disability Services, which also includes the Birth to 3 Early Intervention Program, the Division of Behavioral Health, and Community Behavioral Health, or CBH, which is the city-governed, nonprofit, managed care entity that authorizes behavioral health services for individuals eligible for Medicaid. Today, I will provide testimony on the potential consequences should the Commonwealth of Pennsylvania reduce funding for behavioral health services. I will speak specifically to the City of Philadelphia's services and the possible impact reductions could have on programs and services that support individuals with the greatest needs, including those who are uninsured and services that are uninsurable. October marks the 7th month since the COVID-19 pandemic devastated the entire world. The pandemic is pervasive and continues to harm both the lives and livelihood of millions of individuals across the country. It has exacerbated existing inequities and continues to impact vulnerable and at-risk groups disproportionately. At a time when mental health supports and services are most critically needed, even the possibility of a potential funding challenge for these services is extremely concerning. Given that the Pennsylvania General Assembly passed only 5 months of funding of their budget, DBHIDS has also received only 5/12 of the state-funded portion of its allocation. We understand that the 7 months of funding will not be made available until the General Assembly passes the remaining state budget. The uncertainty of the time frame and confirmation of the fully annualized amount is of concern. The potential impact on the budget for the current fiscal year is unknown at this time. These uncertainties, coupled with the current economic climate, have prompted DBHIDS to proactively explore strategies to provide service continuity if we experience reductions now or in the future. As we explore the impact of a potential budget reduction on services, it is essential to note the funding structure for DBHIDS services. 54% of funds are from federal sources. That includes Medicaid services. That includes Medicaid funds offered through community behavioral health, and approximately 1% comes from the City of Philadelphia's general fund. The remaining 45% of DBHIDS's total annual budget comes from state funding, including the Pennsylvania Office of Mental Health and Substance Abuse Services, or OMSAS, the PA Department of Drug and Alcohol Programs, DDAP, and the PA Office of Developmental Programs, ODP, for Early Intervention and Intellectual Disability Services. The base state funding streams enable us to provide life-saving safety net services that are not reimbursed by Medicaid. These include services that support those struggling with mental health and substance use disorders, such as safe havens, recovery houses, long-term structured residences, emergency mobile crisis services for children and adults, and employment programs. These funds also cover the full continuum of behavioral health treatment services for the uninsured population, including inpatient and outpatient levels of care. In fiscal year 19, through state award funds, DBHIDS served nearly 45,000 uninsured individuals. This includes those who are not eligible for Medicaid, which also encompasses those who are undocumented immigrants. In the future, these numbers may rise as we contend with multiple traumas, including COVID-19's prolonged impact. The Affordable Care Act has also benefited our system as we address insurance gaps and improve linkages to long-term sustainable treatment options. DBHIDS plays a vital role in addressing the social determinants of health. We work to improve and preserve the overall behavioral status of all Philadelphians. At DBHIDS, we take a much broader view of improving everyone's health in a community, not just those with a diagnosis. We support wellness and resilience so that over time, Philadelphia experiences continuously improving behavioral health and mitigates the effects of multi-layered trauma. There will always be a need for access to high-quality clinical care, supports, and services. We are also focused on early intervention and prevention which includes screening for and preventing the onset or progression of conditions. This approach allows us to improve outcomes and better utilize resources. State budget cuts could jeopardize our ability to focus on prevention and early intervention. Funding reductions would likely make it more difficult for providers to fully meet the needs of individuals they serve, which may result in reductions in timely access to the full continuum of care, decreased availability of residential treatment beds, and increased appointment wait times. Instead, in such a scenario, we would be likely to see increases in the number of emergency room and crisis response center visits, the number of individuals seeking shelter services, and the utilization of more acute services. Any level of reduction in state funding jeopardizes vital care for recipients of services. However, it also jeopardizes job security for thousands of people in Philadelphia who are employed by these programs. As we know, a loss of employment significantly increases the need for supportive and social services. Philadelphia continues to be challenged by deep poverty. State budget cuts would only exacerbate poverty challenges in Philadelphia. We must also examine the impact of budget cuts through the lens of racial equity. More than 77% of the individuals served by DBH-IDS are minority populations, and nearly 80% of DBH-IDS and provider network staff are minority populations. Therefore, any reduction in service resulting in layoffs or unemployment will significantly impact minority communities and further increase the current racial and ethnic income and health disparities that Philadelphia is working so diligently to improve. As we look at these concerning economic conditions and face uncertainty regarding potential budget cuts, we know that every lost dollar directly impacts a person, a family depending on us for survival. Before COVID-19, Philadelphia was significantly impacted by multiple layers of trauma. We were combating an opioid epidemic, the highest poverty rates among large cities, economic insecurity, systemic racism, community violence, and all of the associated traumas impacting across multiple social determinants of health. COVID-19 has significantly magnified these traumas. It has been a hardship multiplier. Reducing resources takes us further away from improving health and economic outcomes for the people of Philadelphia. We are thankful to City Council members for proactively examining the potential impact of mental health budget cuts on services for the people of Philadelphia. We are fortunate to have your support advocating for resources on behalf of individuals with behavioral health concerns. My staff and I welcome the opportunity to meet or provide additional information about the content presented before you today. At this time, I am happy to answer questions. Thank you.
Thank you, Dr. Bowen. Also want to note for the record that we've been joined by Councilmember Kendrick Brooks as well. Dr. Bowen, I just have some initial questions before I open questions for members of council. In your testimony, you talked about 1% of your budget comes from the general fund. Can you give a perspective? What's your total annual budget?
Total annual budget is, including the Medicaid dollars, approximately $1.2 billion.
$1.2 billion. Okay, and then just stating for the record, the amount of that budget that is general fund dollars?
Is 1%, or approximately, yeah. Mm-hmm.
And then you also stated that of that 1.2 billion, about 54% comes from the federal government, about 45% comes from the state. And you've been funded so far this year only for about 5 months of funding. So can you state what that amount is?
So to be clear, the amount of funding that is impacted by the 512 is specific funding stream that is particular to state based. So it's not the whole amount that was at risk. And the total amount of that award was for mental health, 145 million. And so that would put at risk approximately 84 million. And then another just about 5.7 million of OAS dollars. So the majority is in the mental health base, where we received 5/12 of the funds. The expectation is that they will go back in and provide the additional 7 months of funding when they get back in and look at their budget. But there is uncertainty about when that would be and whether that would result in the typical full amount of the award.
Okay. And so from your state funding, the areas are mental health services, drug and alcohol, and also disability services. And you gave a little bit of perspective on the mental health, which I think you said was 145 million. What's the amount on the drug and alcohol and disability services that you have received from the Commonwealth?
So the amount that we received, the 5/12 amount that we received on the mental health, just to be clear, we received approximately 60 million. On the OAS side, approximately 4 million. On the IDS side, approximately 10 million. And on the EI side, approximately 8 million. So the amount that's delayed is the balance of the annual amount that we would anticipate.
Thank you. In some of the conversation I've had with individuals in the Commonwealth in anticipation of this hearing, my understanding is that federal CARES dollars that have come to the Commonwealth that have not been encumbered, there's an anticipation those dollars will be used to solve the budget hole for this fiscal year. And this General Assembly session ends on November 30th. Have you had any conversations with any of the state agencies we talked about to get a perspective on what will be coming in reference to finalizing that 7 months of funding that you budgeted for?
Our conversations with leadership at DDAP and OMSAS indicated uncertainty. And we have not received any direct care dollars to DBH IDS.
Okay, thank you. And so my other concern is, especially, and I do have a strong sense, although we don't know what may happen, that those unencumbered federal CARES dollars that the Commonwealth received will be used to fill the budget hole in order to allow your organization to get what was budgeted for the entire 12 months. As you had those conversations with those agencies, have you gotten any perspective in reference to the next fiscal year regarding budgeting or information from them?
Have not. Again, uncertainty, I think, is the word of the day on their part as well as on our part. At this point, the amount for this year is with the legislature, and it's not clear what the following year holds in store, which is, again, why we are grateful for an opportunity to think proactively about what may be coming down the pike in terms of risk to funding sources for behavioral health.
Generally, during this time of year, as we go from mid-fall into late fall, early winter, various departments start to put together their budgets for the upcoming fiscal year, which will start July 1. We all know that the mayor will provide his budget address sometime in early March. As you're starting to put together that information, what type of changes with all the uncertainty that we're dealing with, not only for this current calendar year regarding the budgeting from the Commonwealth level, but as we start to prepare for the next fiscal year, can you give some perspective how this uncertainty is impacting your budgeting process as we get ready for the mayor's budget in the early part of next year?
So our preparation must involve scenarios of various sorts. Our concern will be that budget cuts will impact the types of services that are not as direct care services, but the upstream, the prevention, the community supports, the types of services that build resilience the types of services that support wellness as a focus goes in on ensuring direct care for those who are struggling with those types of challenges in the midst of substance use epidemic and the impact. The national trends are anticipating an uptick in mental health, behavioral health challenges, given the impact of interrupted routines, isolation. We're looking at depression and anxiety being forecasted as people try to re-engage more fully in their environment. So we are looking at trying to predict, again, in the midst of uncertainty, what that might look like. We know from past experiences with budget cuts, acute services tend to go up, emergency rooms get more crowded, crisis residence centers. You look at, again, depression, risk for some suicidal ideation increases. So the focus of a reduced budget would be on addressing these direct services, which are often more costly services. And the concerns would also be in delays of services if there are reductions in the number of hours available, clinicians available to provide the services. So we are looking at steps back. We are looking at focused services, and we're looking at what kinds of reductions. Again, unknown. In the unknown, we have to prepare for multiple possibilities.
Thank you for that response. I want to focus a little bit more on some of the substance abuse concerns because that's a significant part of the work that you do. As you know, the city of Philadelphia has been dealing with a opioid issue for some time. And when I think about what the impact COVID has done on disruption for those who are receiving services, and now we're looking at a possible reduction of resources, that has the potential to even further exacerbate the problem that we are having with opioids. And you made reference to isolation, depression, all things that people are dealing with because of COVID and the fact that we have to be more physically distanced and separated from individuals to make sure we're not spreading this virus. And when we're going into the winter months, and there's been an infection rate increase here in the city of Philadelphia and around the nation, can you give some more specific focus on that issue in reference to opioids and other substance abuse when you combine the virus impact and having less resources going forward?
So when we look at utilization, we've been trying to study pre and post COVID utilization rates, and it's a complex picture. In substance world, we have seen increases in outpatient and residential service demand. That's one of the areas where we've seen increases. It's a complex picture. There's some decreases and some increases. And in the drug and alcohol world, services are more in demand in the outpatient and residential, non-hospital residential areas. So we are concerned that, as I called it, a hardship multiplier. It's crisis on top of crisis. And they feed into each other. Those with substance use challenges may be more vulnerable to medical comorbidities and greater illness if they were to contract COVID. And those who are struggling with some of the issues related to stay-at-home or reduction in routines may be seeking substance use. So they are multiplying and addressing one means you must be addressing both.
Thank you, Dr. Bowen, for those answers to these questions. I'm going to now open up the hearing for questions from members of council. We will hear from Councilmember Helen Im, and then she will be followed by Councilmember Jamie Gautier for questions for Dr. Bowen.
Mr. Chair. Oh, she's back. Sorry.
No problem. Thank you so much, Mr. Chairman. And I appreciate Dr. Bowen. Thank you so much. Could you talk a little bit about services to young people and how they were impacted in the last crisis that we faced, and what you might anticipate happening to young people in the services that you currently have?
So the IBHS services, which I think many are familiar, but it is a new comprehensive rollout in partnership with the state that provides services in the schools. Those services in the schools are for those who are Medicaid eligible. They are comprehensive and include evidence-based practices, specifically focused on cognitive behavioral treatment, which is very effective across the board. Those services are impacted because the school is impacted. And here's we go back to the theme of hardship multipliers. So the families are at home trying the best that they can. Those that are in access centers. So the impact on rolling out the IBHS fully, although they are out there and doing as much work as they can, it's a slower roll. Because of all of the challenges with the changes to the expected basic structure in the planning for an IBHS rollout. So the services are rolling, but there was an impact in the provision, especially in the earlier months of the COVID crisis.
One of the you'll have to forgive me because I'm not entirely clear about how some of the funding worked, but one of the partnerships we also had within the schools was paying additionally for social workers in high needs schools to service that. Is that something that DBH IDS was part of? I know CBH helped use some of their money for it. I wasn't sure if DBH helped do that as well.
Yeah, so there's CBH and DBH IDS providing some supports for the STEP program and the embedding. So any of the services that are embedding in the schools will struggle when the schools are in a different mode. I think there's a fair amount of effort to provide as much as possible. But there's no question of impact. And for those who receive, who are uninsured and receive services that are as much as possible paralleling some of the IBHS, it will be harder to provide the services for the kids with the funding cuts.
Yeah, I mean, obviously with schools having the potential to not be fully returned until September of 2021, hopefully, one of the things that we're dealing with is, of course, if as the financial crisis deepens both for municipalities and across the board, our concern is that when schools do return, and if those services are limited or pulled back, that's going to be an even bigger issue, because those young people will have will definitely need those support services in the classroom.
100% agreement on that, and there's tremendous effort to be as innovative as possible to get it out, even in the current scenario.
Okay. Do I have a time frame yet?
We haven't really talked yet about telesupports, but telesupports are incredibly important. And many of the providers have pivoted, and there's a fair amount of satisfaction with telehealth and telesupports. And I'll just take this opportunity to just acknowledge that anywhere where there remains a digital divide will impact the access to telesupports. but for many of the programs, including some of the ones for children, they're using every potential innovative approach to continue to provide the necessary supports for the kids in the current climate.
So when you say, I mean, can you already see the gap around telehealth? Because there is a digital divide that we're pretty clear about. The city has made a significant commitment to ending the digital divide in Philadelphia, but I feel like you already have clients, right? You're moving to telehealth. What clientele, like, can you quantify the gap at all as the move to telehealth has been greater, and what you see in terms of the digital divide on your end?
Yeah, I think much of that has been affected in terms of improvements in that area. I think that we still are looking at that. We are evaluating a lot of what is new out there. We do know that for some, telephonic is helpful, even if there isn't more available than that. But I think we need to be cognizant of that as we go forward, especially if there's an uptick, because face-to-face treatment services are down and telehealth is up, and we want to just make sure that everyone has equal opportunity to receive services.
So do you have a number, or are you trying to track a number on how many clients that you had previously that you had reached in person versus the numbers that you're reaching through telehealth?
The numbers that we have on that right now are about 77. We did a survey on telehealth for the providers. About 77% of the services were able to shift.
77%, you said? Okay. You know, one of the things that we noticed, certainly when schools shut down, and, you know, we try to reach families and children in particular, one of the starkest and harshest realities is that we actually lose children entirely. We're not able to find them. They disappear kind of off the books. There may be a bad address, the email doesn't work, the phone's been disconnected. And so, you know, it's a constant reminder of how important it is and how fragile families are, and that our connections to them are really important, and relationships matter. They can't reconnect based on basic services, but they can find people if the relationship is strong. Have you seen some of that with some of the clientele that you serve also, like during the pandemic? Have people, like, can you talk a little bit about dislocation, or whether, you know, it's not just a matter of services and access. It's sort of like, how are, you know, people existing in this moment?
So I don't know if I can speak to that exactly, Council Member, but we do look closely at utilization. And initially, utilization was down, and it seems to be making its way back up to pre-pandemic levels, but it is variable across the types of services. And so we are really paying a lot of attention to that and trying to sort through, looking at different levels of care and where people are showing up. In psychiatric services, for example, inpatient hospitalization is up. So we're seeing some more people there, but outpatient is down. Though it's up with the substance use population in terms of outpatients. So we're really trying to understand this complex picture of where people are and who's coming into services that maybe hadn't before, and who's coming into services continuing. There's a tremendous effort on the part of a really exceptional provider network to maintain contact with people who have been in treatment. And again, the telesupports and the telehealth is really a critical part of that. We also pay attention to crisis lines, and there's a mixed picture there as well. Initially, there was actually a decrease in the number of calls, and then it sort of returned to the sort of average call level. And then occasionally there will be an increase in the number of crisis calls. Again, this is a reason to be concerned about any kinds of cuts, because the system had already been sort of innovatively moving to increased mobility and increased availability of ensuring contact with folks. And so we want to be able to continue to develop that approach to whether it's crisis or ongoing treatment services.
Yeah. So my last question, thank you very much for that. So my last question is that, I'm trying to think about how we would, have done things differently, and how we're going to approach this new financial crisis, which is, quite honestly, inevitable, a lot differently from what we had, a decade ago. I know that in our school system, we took out nurses and counselors. We distributed them 1,000 to 2,000 to 3,000. Nurses were, barely in place in a huge majority of schools. I think it had a lot to do with the fact that there weren't pre-existing systems, or I don't want to use quotas, student ratios that would have protected it. So in fact, what ended up happening was that people went back to the most extreme ratios and then cut back from there if they could argue that, there was any kind of gap or opening. So in this particular case, legal precedent does matter, ratios, any types of things that ensure or guarantee things matter. And then I would say that the other thing that we lacked really was, especially in terms of mental health care and treatment, and our institutions, and I'll definitely get to you, but I think that it wasn't considered a core part of the mission, and so it fell to the wayside. So education was considered a full part of the mission, preserve teachers, et cetera. There could not be like a nuance or some kind of balancing or another kind of priority system that came in place. So we existed back then. We closed down multiple schools. We had children die in schools without nurses. We saw our graduation rates plummet when there were no counselors in the schools, especially in that first year. As in your field, and we went through those devastating, what is 100+ million, it's 9 figures, right? It's like insane amounts of money. You saw kind of like the heavy hand that came through. How would you have done things differently? Like how are you thinking about it in a way that resets our priorities so that we can approach any future financial crisis differently in a way that values mental health treatments? And what would you have uplifted that you felt did not get uplifted in the last crisis?
So first, I think uplifting and you use the word priority, and I think it's extremely important when you're in financial crisis, but it's also extremely important when you're thinking of the clinical health and the behavioral health and the health of a population. So priorities are incredibly important. And priorities today are very focused, and we must have an awareness of social determinants of health. Those aren't just words. That's real. So you can't separate out and say, oh, well, we will cut this piece and we will cut this piece. Every piece you cut affects it's ripples. They're all integrated. So if you cut in the schools, you're going to be impacting behavioral health. If you cut behavioral health, you're going to be impacting the schools. I think it has to be looked at in an integrated fashion. We have great awareness of the social determinants of health and the impact. And to be honest, every social determinant of health is traumatized right now. If you look at physical health and COVID, and you look at substance and opioid, and you look at the school systems and how that has undergone trauma, and you look at criminal justice. So every social determinant of health is being strained and stressed. So when you prioritize, it has to be different. It can't be siloed. And you have to look at cost efficiencies. As I said, acute services are more expensive. So there has to be, intentional, thoughtful, planful. And it's really hard to do that, but necessary to do that. So the idea of going to a scenario where it's, remove certain people based on ratios is concerning. Hopefully we have learned from some of those experiences that we have to look at the big picture and the small picture at the same time. The big picture in terms of how do we address this and maintain the integrity of the systems while simultaneously thinking about the individuals, the families, and the communities that we serve.
Yeah, thank you very much. Those are all my questions. My only comment would be that I do think that things that weather financial crises are, as you said, groups that have figured out systems in which there's good integration. So if our investment right now in fending off what we know likely where things are going to hit and who's going to be most vulnerable. So it seems that the strengthening up of the collaborative systems and the inner workings of, the different institutions overlapping together, like if those are strong, then I think they weather it better. If those are weak, or we think that they can start up as soon as, the funding starts drying up, I think we will be on the back foot once again. So I look forward to just continuing to be supportive around strong integrated systems of care, and reprioritizing, recentering mental health treatments, and then re-emphasizing programs that work, what it is clearly that people could need, and then our level 1 priorities, level 2 priorities, level 3, because I think that kind of clarity really made a difference. And that's certainly what we're going to be looking at when we, as we talk about the possibility of budget cuts. Thank you.
Thank you.
Thank you. We'll next hear from Councilmember Jamie Gaultier, to be followed by Councilmember Cindy Bass, and then Councilmember Kendrick Brooks with questions.
Thank you, Mr. Chair. My first question is similar to Councilmember Gim's. First, good morning, Dr. Bowen. Thank you for joining us. I've been going around and talking to the principals in my district, and just trying to get a sense of how they're operating in this landscape and how our students are faring. And one of the consistent concerns that comes up is around the way that we're able to support students in this time. And one of the concerns that I've heard more than once was around children who were previously getting served by DBH IDS and now don't have as easy access to those services, even though they need them, right? And probably need them more now. And so I wanted to ask you about, I know that the agency is doing its best to respond in this moment, but how can we put our heads together with those principles around serving children at a time when they're most in need? Yeah,
I have to say that the providers are doing a really good job working to keep up with the kids that had been, identified through the through a number of means, including at some of those access centers. I think every opportunity to be working collaboratively on some of these challenging areas is needed. And I think already DBH-IDS was involved in that kind of collaborative work, along with the Health and Human Services cluster. And so I have every expectation that will continue with this sort of focus on where we are with our current situation. I do want to say that we are committed to school services. We have always been adding services and improving the services. The IBHS is an excellent service that is rolling out. It's really comprehensive and a really good step forward with excellent providers that are very busy and receiving supports and collaboration, meeting regularly with CBH leadership, looking at their funding streams and what is needed for them. So all of that is very much underway.
Thank you. One of the things that I promised to my principals was that I would broach this topic and see what we could do from a problem-solving perspective. So if there's any ability for a group of them to talk to you or to talk to the most appropriate person about school services and how we weather this time, we would appreciate that.
Absolutely welcomed. And I think to some degree, quite a bit underway already. Yeah, but absolutely welcome. Thank you.
Okay. My second question is around gun violence and the dramatic spike in gun violence across the city, but particularly in many areas of my district. How has the gun violence epidemic impacted the amount of services that you are providing to people within neighborhoods, and how are you thinking about interacting with this epidemic as the numbers around shootings and homicides continue to rise?
So our trauma and support services are well in place, have been throughout the pandemic, and support, along with our partnership with NAMI, our trauma and resilience team. There were customized sessions for essential workers out in the community with network of neighbors, training Trauma 101, and working with our partners in fire, health, and police to mitigate impact of COVID-19. Again, hardship multipliers, multiple traumas, and the supports that we have in place are active and have been. Our outreach teams are out there, our community wellness engagement units. We have been building, even before the pandemic, we have been building teams to support, strengthen resilience and to support communities on addressing trauma and working with the Office of Violence Prevention and other efforts. I think DBH-IDS has been a partner with the criminal justice system and trying to work on innovative approaches to some of our biggest challenges.
Have you seen a change in the levels of services that you're asked to provide as the gun violence epidemic rages on? And has there been any specific conversation about increasing services to our neighborhoods as the epidemic goes on? And how are you thinking about that?
And how am I? Please repeat that. How am I?
Have you seen has the agency had to offer increased services as gun violence has increased in our neighborhoods? And has there been any explicit conversation about whether we're equipped to interface with the huge amount of trauma happening as a result of gun violence? And has there been any conversation about increasing services or capacity to handle it?
Yeah, we're out there with the communities and responding. We have a number of approaches. We have already been looking, even before COVID, with awareness of the trauma to communities, the violence. We support programs like Ceasefire. So we have been steadily increasing, and even through the pandemic and the effects and impacts, we're out there in the communities, and we're supporting our programs. So the expansion is a continuous improvement to try to address and understand and work with our partners, clearly in partnership with Office of Violence Prevention and Safe Streets. We are an important partner with all of these approaches and innovations, clearly those who are in need, perhaps increased need due to the impact of violence in the communities. We are increasingly training staff as well to be able to address. So I think at every level of the continuum and every level of our involvement in the community, this is absolutely interwoven and extreme priority for us.
Thank you. Thank you, Mr. Chair.
Thank you. We'll next hear from Councilmember Cindy Bass for questions.
Good morning.
Good morning.
How are you?
Okay, how are you?
I'm very well, thank you. Can you talk about how you are assisting residents in nursing homes who are diagnosed with behavioral health problems through COVID?
So,
how has your operation been affected?
Yeah, so nursing homes is not particularly specifically under DBHIDS, but I would like to talk about congregate settings and our role in supporting folks who are vulnerable due to 65 years of age or older, for example, or those who have medical vulnerabilities. DBHIDS was instrumental in helping to stand up quarantine and isolation sites and integrated supports for those who are most vulnerable in those sites. It's very difficult for many to be isolated, especially if you're struggling with behavioral health challenges. The COVID prevention spaces, which also supports those who are in congregate sites and in need of a space, especially if they're experiencing shelter insecurity as well. So we have been very involved at those levels. Some of our congregate sites were affected, and some of those serve an older population. Some of those are settings that may refer to nursing homes. They did experience some significant challenges, especially during the early months. So there were some strategic changes that occurred in some of how the congregate settings, those serving the older population included, were restructured. Some of that had to do with separating beds further, or redesigning program space for living space. Many of the residential programs, the congregate settings of various sorts, were designed to be able to support a good number of people and to encourage social engagement. It's kind of the opposite of the kinds of settings that we need to stay safe. And so a tremendous amount of effort went into redesigning the congregate settings and the residential levels of care that DBH-IDS funds.
Okay. All right. Well, thank you. Thank you. Can you talk about like the transition into the community? Because we know that, particularly in light of COVID, there are a lot of families who no longer want to do the traditional care settings, and including nursing, nursing facilities. And are there transition funds or resources available that DBHIS provides for someone who has transitioned out and on their own into the community? Are there any services available?
There are services available for people in need of behavioral health supports. There have been, and some of those services can be provided in a mobile capacity. Some of them can be provided through telesupport. So there's a range of ways in which folks can get the services that they need. And that cuts across many different challenges. There's been a lot of effort to work with our partners at the state on regulations that may have needed to be adjusted. Telehealth not being the least of it. Other challenges in terms of, let's say, folks who may need MAT access, but they're in isolation. So there were all sorts of new challenges. We were, I think, incredibly well positioned, given that we were already working to enhance our flexibility, our ability to provide treatment on demand, our work to improve access to care and to increase mobile presence. So that allowed us to kind of look at what we were already doing and see what needed to be enhanced and adjusted. And so much of that has, evolved a bit. But we're still pushing to further that effort. Another reason to take us back to the concerns about cost cuts, because these types of efforts, are shift a system to bring services where people are. The goal is to bring services where people live, where they learn, where they pray, where they congregate. This is what the goal would be. And so a more mobile, flexible, responsive system. The fact that we had already been moving in that direction was an advantage as we needed to adapt to COVID.
Go ahead.
I just want to say IDS also, Intellectual Disability Services also supports people's integration in the community. And again, Community Health Choices supports older adults with behavioral health in terms of, that work that CBH is involved in as well. So I think there's a number of places where there's an intersection. And again, hark back to social determinants of health, and so support for people who are experiencing shelter insecurity, for example, food insecurity, difficulty accessing, testing, having people with lived experience supporting people during a particularly challenging time. So all of those, of course, were at play and are at play.
How do we, and this is my last question, Mr. Chairman, how do we make sure that those resources are known and out there? How do we put the word out? I have someone close to me who works for Liberty Resources, and they do an awesome job of those transitions of moving people into the community with various disability needs and that need to be met. So how do you interact with, let's say, a Liberty or with another provider to make sure that we have completely addressed the needs of someone who's moving into the community?
Yeah, so there's a number of ways in which we bring awareness to folks so that they know what the resources are. And some of what has been put into place were ideas that came from our stakeholder partners, from community directly, from city council members. And some of that includes community-based teams that are out there interacting and bringing the knowledge and the connections, making the linkages. We launched Mindful Together as a partnership with Independence Blue Cross. That is still up and active. It's just chock full of information for folks. So you can go to Mindful Together. Also, Healthy Minds Philly has a lot of information, as does the DBHIDS website. So we encourage people and we connect there. So between teams out in the communities, case managers that the providers provide, and the multiple ways in which we list and share these resources, we continually work to get the information out and to link folks to the services and the treatment that they need.
Thank you very much. The other thing that I would like to add is that I would encourage, Mr. Chairman, in your role and also as the chair of the Committee on Health and Human Services, that maybe we could do a briefing through City Council for council members, because as you know, we get a lot of questions and don't always have the answers. The products, the services that you offer can be quite complex, and so maybe myself and the chairman, we could work together to put together some briefings on behalf of council members so that we could stay up to date on what's out there, what's available. People come to us for all sorts of reasons and questions and concerns, and the more information we're able to provide them and to direct them appropriately, the more of a service we can be to our constituents. So I just wanted to put that out.
We're very, very happy to do that. We did do one last year and happy to do, especially given some of the challenges this past year. Very happy to schedule that, to upgrade it. And we also are aware that you are a point, City Council, appropriately for folks to come in and ask. And so we want to make sure that you have all of the information that you need and the connections to us as well.
Well, thank you so much. And thank you for, your briefing last year. And I'm thinking that we could do something on a regular basis, maybe once a week, or no, I'm just kidding, not once a week.
I was thinking daily. We would just or let's just have coffee.
Well, but on a regular basis that we could schedule something so that we can get the information out to the community. So thank you.
Thank you.
Thank you, Mr. Chairman. Thank you, Jim.
I think that's actually a great idea. Also considering that Dr. Bowen, you are new into this position, that would be a great opportunity to introduce you to members of council by having that type of briefing, as well as providing information on how members of council and their offices can provide services to constituents who are dealing with some of these issues, especially during this pandemic, because life has changed so much dramatically since we had that last briefing. So I think it's a great opportunity to introduce you to other members and their staff, and we look forward to working collectively through this committee and the Public Health and Human Services Committee to set up that type of briefing. Thank you, Councilmember Bass.
Thank you, and I just did want to correct myself. I referred to the doctor as Jill. I'm all familiar and whatnot, so I want to give her her respect too, Dr. Bowen. Give my sister her respect too. Thank you.
Well, there are a lot of great Dr. Jills doing things this time of year, both here in the city of Philadelphia and around the country. So we will end with that. And so We next have some questions from Councilmember Brooks, and then we will go into the next panel if there are no other questions from members of council, and to let members of the audience know and members of council that the next panel will be the following: Sherry Brummins, Dr. Adriana Torres O'Connor, and Malcolm Musgrove. And that will be the next panel if there's no additional questions from members of council. And at this point, we'll hear from Council Member Brooks.
Thank you so much, Mr. Chair, and thank you so much, Dr. Bowen. I want to echo my colleague's concern about what a loss of funding for your department would mean for the city of Philadelphia. So can you talk more about the plans to fund supports for like addictions, mental health, and children with these cuts to your budget? And are there future opportunities for the department to receive increased federal grant funding? Because we know without, the state's allocation, it'll be hard to fill those budget holes moving forward. And I have another part to that question, but you want to answer that part first, and then I can.
Yeah, I'm not aware of any additional federal fundings, that are coming down the line, specifically outside of potential COVID or other stimulus type of money that may be under consideration. The federal funding at this point has not been at risk for this year. The uncertainty that we're focusing on is the state specific funding stream and the state base, and the reason that the concern originally came forward was because we got 5/12 of the money thus far this year for that funding stream. The federal funding stream at this point was not affected. I do want to say that we go after every available grant we can. That is a focus of our efforts. And so we look for, we apply for any other supports that we can that is a part of our overall strategy. I think that in answer to your question about substance and mental health and children's services, all of which would be at risk, we are really talking proactively here, thinking forward about what may be coming down the road. I think appropriately so, given the crisis in in Philadelphia, on top of the poverty that already exists, the unemployment, and the behavioral health repercussions. So those are the concerns, and why we are so grateful to have this opportunity to talk about this. We also work very hard to, and want to just emphasize again the importance of the ACA in the work that we do. We work very hard to help those who are not Medicaid enrolled but are Medicaid eligible to be able to flip them onto Medicaid dollar. If we had reduced funding, it would be difficult to continue to do that. If there were challenges to the ACA and the folks who are served through Medicaid, we would have additional concerns. So I think, again, we go back to the word uncertain, and uncertainty brings with it a certain amount of anxiety and the need to prepare for multiple possible scenarios.
Thank you so much. I have another question. That was very helpful. So my other question is, what are your plans to fulfill the anticipated increase in services related or due to COVID? Whether it's related to the gun violence crisis that we have right now or COVID deaths. I spoke to someone the other day and they mentioned they had 8 family members in their family die from COVID. And I was traumatized just by hearing that. I and I don't know how that would result in like one particular family and what were the potential outcome, especially if it's a family that are already connected to these services. So do y'all have plans to, like, what is the plan to fulfill that potential increase?
So the network is able to serve all of the needs of the folks at this point. We have the ability within our provider network, if necessary, and if we had funding, we can expand the network. We always, CBH in particular, focuses on network adequacy and assesses to make sure that we have capacity in the event that we began to exceed our capacity or we're not able to provide timely services, we would need to expand. I'm particularly concerned that we not reduce. We are working on community strategies in terms of virtual grief supports, the scenario you laid out. The loss is staggering. And for sure, the grieving is part of what we are expecting is going to be driving an uptick in the need for behavioral health services going forward.
Thank you. I have a few more. I wanted to talk about the potential layoffs that you mentioned in your testimony. We know that DBHIS is a leader in the city's workforce as it relates to hiring Black and brown workers. So I'm really concerned that the budget cuts will lead to deepening poverty for working people throughout the city, while also further neglecting the vulnerable populations that they serve. Have there been explicit discussions of personnel cuts so far? And where are those cuts anticipated?
So again, we are thinking proactively here. So at the present time, we do not have cuts and are not identifying layoffs. What we're planning forward for is to try to prevent that scenario. There are folks at DBHIDS whose work is tied to grant funding. There are providers whose work is tied to grant funding. A contraction or a constriction of funding and of services will inevitably have that kind of an impact. So we need to be cognizant of that piece of this scenario when we look at these potentials. Every reduction scenario looks at the potential for constriction. And I really want to thank you for raising that issue and making sure that that's highlighted, because those we serve and those who provide the service are all part of the same community and all part of Philadelphia. And this will have repercussions that feed on each other. Losses of folks who provide service means less service. Less service means longer waiting times, more illness, more need for acute services. Those who become unemployed are now stressed with economic insecurities, and that feeds into behavioral health challenges and needs. So there will be more need for social services if people are laid off with less capacity to provide it.
Yeah, thank you for that. Because my concern also was, like, as a former mental health worker, I used to be a behavioral specialist, what we do realize is that with staffing shortages, that means increased workloads. And that means the folks that are most in need will get limited care when workers are stretched very thin. And I just wanted to make sure that part of that analysis includes what would increased workloads look like, because what we do realize, God forbid, that if you do have to cut staffing, the need of the clients already served will not be reduced. And that's just a major concern that I have. Unemployment, how it affects the communities and also how it affects the services in those communities. And I just want to make sure that the potential increase in workload and what that looked like is definitely considered from a worker's perspective and also from a family and caregiver's perspective.
Absolutely agree. And again, these are inextricably tied. I do want to also just be clear that at this point in time, we do not have a reduction. We are expecting that that other 7/12 to be considered by the General Assembly, but the economic scenarios must be considered given the realities. I just want to echo how important it is for direct support persons to be present and serving at the multiple levels of care throughout our system, throughout mental health, substance use, intellectual disabilities, early intervention. We need these folks in place and providing the services in these most difficult times.
Thank you so much, Dr. Bowen, for your comments, and also thank you, Mr. Chair, for the opportunity.
Thank you, Councilmember Brooks. As we prepare for the next panel, which will include Sherry Brummans from the Alliance of Community Service Providers, Dr. Adriana Torres-O'Connor from Mental Health Partnerships, and Malcolm Musgrove from Marikey. Just have one last question for Dr. Bowen, and I don't see any additional questions from a member of council. And Councilmember Brooks talked about this from an impact from a workforce perspective, but also I think one of the things that is lost sometimes in this conversation is that although these dollars are coming as federal and state dollars to the city of Philadelphia through your department, this also, and they go to nonprofit organizations, this also has a significant economic impact on our city. When you're talking about a budget about $1.2 billion, and we're going to hear from providers next, of the money that you receive on an annual basis, how much would you say go to providers through contract? Either I would mention a good number of those dollars go by way of provider contract from CBH to those providers, and DBH IDS does a contract with community behavioral health. But from your understanding, how much of your annual budget are contracts to providers that provide that ecosystem of services for the issues we're talking about will directly impact them and also have a significant impact on our local economy?
So about 90% of the funding goes to the provider network. That's what the funding is for. It's for the provision of behavioral health and intellectual disability services. And the economic impact for the city is a 9-to-1. For every $1 the city puts in, it's $9 from the grant funding. And as an economic impact on the city, it's a very positive economic impact for the city. And the loss, this is not, I think as a theme of what we've been discussing today is systems integration and the impact that is not in a narrow silo. This is impacts for providers, for people who receive services, for the community, and for the economic health and well-being of the city as well.
Thank you. And when you think about the fact that this year City Council had to grapple and close a $740 million deficit in order to start this new fiscal year, and as we're going into a new fiscal year, FY22, the fact that we're already grappling with a loss of significant revenue in the general fund, and then when you have the potential cuts that may occur at the state level that will go to DBH IDS and then impact providers, that just shows how crippling any additional cuts, not only for the services that we provide, but also the economic viability of the city is so important. And that's why raising this issue is important now, so we can kind of think what we need to do, not only to make sure that we can continue to provide all the services that we need to do for our constituents, but also how it's going to impact our city from an economic perspective as well. Dr. Bowen, thank you for your time. Thank you for your questions. And we look forward to hearing from you in the future in a briefing with members of this committee and members of the Public Health and Human Services Committee and other members of council regarding the work you're doing. Thank you for your time and commitment to this issue.
Thank you.
With that, we'll now go into our next panel. I would like to have Mr. Iannuzzi call the next panel for this hearing. As you are connected and become ready to proceed, please state your name for the record and then begin with your testimony.
Are we waiting for Mr. Iannuzzi to call us?
I'm sorry, Mr. Chair. Sherry Brummins, Adriana Torres O'Connor, Malcolm Musgrove.
Thank you. If you could proceed in that order, just by stating your name and then proceeding with your testimony.
Hey, good morning, Sherry Brummins. Good morning, Councilman Green and distinguished members of City Council. My name is Sherry Brummins, and I'm the CEO and Executive Director of the Alliance of Community Service Providers, affectionately known as the Alliance. I thank you in advance for the opportunity to testify before you today. The Alliance is a trade association that represents organizations in Philadelphia that provide services and supports to children and adults who struggle with mental health issues, substance abuse issues, intellectual disabilities, and autism. We are committed not only to providing the best possible care to those in need, but also to ensuring that the voices and needs of our member organizations are heard and acknowledged. I'm sitting before you today to provide an update on the impact that COVID-19 has had on human service providers in the city of Philadelphia. First, it's important to contextualize my testimony today by reminding you of what you probably already know. Providers of critical life-sustaining human services are operating within razor-thin margins. Unfortunately, this was the case long before COVID, and it remains true now and probably will remain true in the future. Most do not have significant cash reserves or endowments from which they can draw from when times get tough. And as I think we're all aware, times have certainly gotten tough. So to put this into perspective, and recently we did an Alliance survey, and we found that nearly 90% of our agencies have incurred over $100,000 in COVID-related expenses. That's $100,000 that is not reimbursed. That is $100,000 that nobody expected prior to COVID. And over 55% report having 3 months or less cash on hand. We expect that this will continue to worsen as we approach the winter season. These harsh realities are a result of a perfect storm comprised of lost revenue from not being able to render services at pre-COVID levels, plus the addition of many unanticipated expenses related to the safe continuation of these services so that they can be offered. It should come as no surprise that securing adequate personal protective equipment, or PPE, has been both difficult and quite expensive. While the supply of PPE is more plentiful than it was at the start of the pandemic, costs for these items continue to be sky high. These costs are generally not reimbursed, and our providers need additional funding to give direct services workers the tools they need to protect themselves and their families and those entrusted to their care. To be clear, our direct care workers require the same safety equipment as essential hospital workers. They are indeed essential workers. It's unreasonable to ask our DSPs, direct support professionals, or essential workers to take on the same risks without giving them the same resources. It's just not optional. But these struggles are only one part of the story. So despite their best efforts, providers continue to struggle to retain workers and avoid layoffs. Direct care workers are doing very risky, difficult jobs for substandard pay, which leads many to burnout and ultimately to a decision to change career paths. Substandard pay is nothing new for direct care workers. We've been fighting this battle for a very long time, but in the face of a global pandemic, it is downright inexcusable that we cannot afford to pay them a living wage. Fortunately, our behavioral health providers have been receiving payment in the form of an alternative payment arrangement from CBH. This has been helpful and we're very grateful, but it does not cover the increased cost of providing telehealth, hazard pay, and other expenses related to COVID safety. Additionally, there's been a noticeable increase in the need for mental health treatment, which ultimately results in providers expanding necessary services. Without proper funding in the future, these providers could be at risk of closing, laying off staff, or significantly decreasing the services that they offer. Alternative payment arrangements have kept many of our behavioral health providers above water, and for that we are very grateful. But that option is slated to go away in January, and at this point, we believe the situation will become even more dire as COVID gets worse throughout the winter months. State-funded intellectual disability and autism day program closures have been decimating. Many providers have been unable to continue, and even as some programs have safely reopened, it's at a drastically reduced capacity. Not only were there long stretches of time when billable activity for day programs could not happen at all, when revenue-generating services do resume, they happen less frequently with fewer people than usual and carry with them additional costs and risks associated with keeping people safe. Simply put, human services providers everywhere are struggling, whether it be behavioral health or intellectual disabilities and autism. This pandemic has had a pronounced impact on the physical, mental, and emotional health of everyone. Some organizations have become overwhelmed as more residents are seeking services from a smaller pool of providers and costs have outpaced revenue. And as resources have diminished, it's become more difficult to provide the quality of services that those with behavioral and intellectual disability challenges require. So before I conclude my remarks today, I'd like to pose a couple of questions to City Council. Will providers of essential services be given the assistance they need to account for additional expenses and lost revenue related to COVID moving forward? And as I know we're already all aware, Pennsylvania is facing an almost $4 billion budget deficit. Our members are waiting for a new budget to pass in November, and we are anticipating significant budget cuts. How will the City of Philadelphia help providers if the state cuts our funding? We have a responsibility to take care of our city's most vulnerable citizens. In addition to significant widespread trauma, violence, systemic racism, and extreme poverty, I believe we are at the cusp of a burgeoning mental health crisis. I think it's safe to say that we can all agree we cannot cut funding if we expect things to improve. We do not want to emerge from COVID crisis only to find that providers have closed. This would not be good for people who receive services, nor is it good for the employees of these organizations or the City of Philadelphia. We are asking every single member of this body to please fight for us in Harrisburg, ensuring that funding human services is a priority. Each of us has a role to fulfill, and we must do so intentionally. I thank you for your time today, and I look forward to speaking with each one of you individually in the coming days, weeks, and months, and I welcome your questions now. Thank you.
Thank you, Ms. Brummins. Before we hear from questions from members of council, I want the entire panel to testify. Next, we'll hear from Dr. Adriana Torres-O'Connor, Malcolm Musgrove, as well as Sarah Molina Robinson from PHMC.
Good morning. Can everyone hear me? Wonderful, yes. Thank you. I am Dr. Adriana Torres-O'Connor, President and CEO of Mental Health Partnerships. Good morning to council members. I would like to thank you for this opportunity to contribute my testimony to this very important matter. Special thanks to Chairman Derek Green for your tireless leadership and for inviting me here today. Since 1951, Mental Health Partnerships has been providing programs, services, and advocacy to thousands of Philadelphians and their families struggling with mental health and addiction challenges. We have pioneered peer support as a way of recovery for those experiencing mental health and addiction challenges. My staff have walked intimately in terms of the journey of recovery and are trained to use their lived experience in partnership with individuals and families with mental health challenges to promote recovery and resiliency. Like the thousands of mental health professionals throughout this great city of Philadelphia, our staff, as Sherry said, are frontline and essential workers. They have stepped up to ensure that services not only continue to support those in need, but actually increased without additional funding to meet the increasing demand caused by this pandemic. The numbers speak for themselves. Prior to COVID-19, just 8 months ago, 1 in 5 adults, that's 20%, experienced a mental health challenge in their lifetime. That's over 211,000 Philadelphians. The most prevalent diagnoses were anxiety and depression, and the diagnosis of depression alone costs Americans $193.2 billion a year in lost earnings. This is a compounding effect on the local and larger economies, given Philadelphia is one of the largest economies in the country. Since the start of COVID-19, only 8 months ago, those impacted by mental health and addiction challenges have skyrocketed. Adults experiencing anxiety has increased by 30%. Adults experiencing depression has increased by 40%. Adults experiencing trauma and stress-related symptoms has increased 25%. Adults who started or increased their use of drugs and alcohol to cope with COVID-19 related stress has increased 13%. Adults who have seriously considered suicide in the last 30 days has increased by 25%. These increases in the number of people impacted by mental health challenges as a result of the COVID-19 pandemic have disproportionately affected young adults, Black and Brown communities, essential workers, of which includes mental health workers, like my staff at Mental Health Partnerships, and those with pre-existing mental health conditions. These increases are not just numbers, they're people. They're the citizens of Philadelphia. The reality is clear. COVID-19 and its effects are not going away anytime soon. It is also clear that mental health funding is more critical now than ever. Any cut to mental health funding will compound the increased trauma and mental health challenges that people are experiencing now, which has already resulted in an increase upwards of 40% of people experiencing mental health challenges. A cut to mental health funding will further compound the lost earnings experienced by those with mental health challenges to the extent that the $193.2 billion in lost wages will look like a drop in the bucket when compounded with the increase in mental health incidents and current job loss caused by this pandemic, which itself is triggering mental health challenges. It is clear that this pandemic has created budget shortfalls at all levels of government. It has caused great strains on small and big business alike. However, nonprofit mental health organizations like Mental Health Partnerships will be especially hit hard by decreases in government funding just when they are needed the most. And this will not only have short-term consequences for the mental health of Philadelphia's residents, but will have long-term consequences to the health and stability of citizens that result from increased costs to the overall economy. In closing, it is absolutely necessary that funding for mental health be made a priority and not placed on the budget back burner. Thank you for your time and for having me today.
Thank you. We'll next hear from Mr. Musgrove and then Ms. Melina Robinson.
Good morning, Malcolm Musgrove, Vice President of Behavioral Health for Marikey. Good morning, ladies and gentlemen and members of council. I'm honored to be here today to share my testimony on the consequences of potential cuts for behavioral health care funding in the city of Philadelphia. I'm speaking to you today as a representative of Marikey, one of the largest not-for-profit providers of behavioral health services in Philadelphia, and as an executive for over 20 years of experience in mental health care, and as a lifelong resident of the city of Philadelphia. Access to adequate behavioral health care is critical to create healthy communities. Before the start of the COVID-19 pandemic and accompanying economic anxieties, we faced significant challenges in caring for Philadelphians. The opiate epidemic, rising suicide rates, and significant access issues prevented people from receiving the services they need. The Southeast Pennsylvania Community Health Needs Assessment ranks substance use and mental health care as the most important community health priority for our region, and notes that our most vulnerable community members are those most in need of behavioral health services. This includes those living in poverty, racial and ethnic minorities, immigrants and refugees, LGBTQ plus community, youth, and older adults. The current crisis only amplifies the need for mental health and substance use disorder services and increases barriers to individuals seeking treatment. People suffering with mental health and substance use issues are more likely to rely on Medicaid and public health programs for support. Reducing funding to this vulnerable population will not only have a devastating effect on the individuals who rely on the use of services and their families, but also to the community and the city as a whole. Access to behavioral health care not only improves the lives of individual citizens, but it also improves the quality of life within our communities. Access to care for individuals in need reduce the likelihood of criminal activity, homelessness, overdose deaths, and spread of disease or illness. It also increases the overall productivity of Philadelphians by increasing participation in work, education, volunteer activities, and reducing involvement with the criminal justice system. Behavioral health care can improve an individual's overall health and well-being and reduce total health care costs. Individuals with severe and persistent mental illness have shorter lifespans and more medical conditions than the general population. Social economic anxiety, food insecurities, lack of housing, and employment issues go hand in hand with mental illness and addiction issues. Untreated mental health and substance use issues result in higher utilization of emergency room department visits, increased hospitalizations, and greater healthcare expenditures. By addressing individuals' basic needs, we are paving the way for their recovery and their ability to participate in their communities. It is up to all of us, legislators, community members, provider organizations to ensure that we are providing access to community-based services and supports that our neighbors need. Access to care does not simply mean having provider organizations operate within the system. It requires provider organizations that are able to meet people where they are physically, culturally, economically, and where they are in terms of their treatment. Mental health providers need adequate funding to deliver high quality care that Philadelphia communities deserve. Funding that will enable us to hire qualified staff, implement telehealth and other new technologies, utilize evidence-based practices, and to better coordinate care with physical health providers and social service supports. Mental health care is an essential component to the city's public health. The funding of mental health services is not only investing in the individual Philadelphians, it is investing in the whole community. Thank you for the opportunity to share this testimony.
Thank you, Mr. Musgrove. At this point, we're now hear from Sarah Molina Robinson from PHMC.
My name is Sarah Molina Robinson, and I'm the Chief Educational Services Officer for Public Health Management Corporation, PHMC. Good morning, and thank you to Councilmember Green and all the members of City Council for this opportunity to speak with you today. And thank you to Dr. Bowen from DBH IDS and my colleagues from the Alliance of Community Service Providers, Mental Health Partnership, and Marquee for your leadership, partnership, and commitment to this important issue. While I'm relatively new in the role of Chief Educational Services Officer, I've had the privilege of working in the public health community for nearly 30 years, specializing in the needs of children with developmental delays through our Childlink program and individuals with intellectual and developmental disabilities through our Personal program. This work has placed me and my team front and center in the lives of families painstakingly searching for critical resources for their children and for their family members with special needs. And in the case with nearly all of the people touched by PHMC subsidiaries and programs, the children and individuals served by Childlink and PersonLink have complex needs. In fact, we estimate that 85% of participants in PHMC's behavioral health services are duly diagnosed with both mental health and substance use disorders. And while my teams are not directly delivering mental health resources to the individuals and families we serve, we are keenly aware of how vital these services are in the lives of our participants and their families. As we sit here this morning, we're providing support to parents of a personal participant in the midst of a 2.5-year odyssey to find appropriate level of mental health care for their adult child with IDD. I can only imagine the level of relief by the parents when they learn that community behavioral health approved mental health resources for their child. Their relief must have quickly faded into frustration when the only program offering the appropriate level of mental health services wasn't able to accommodate their child due to a lack of staff, resulting from decreased funding. The struggle of these families is all too real. The resources are already far too few, and the current environment of an ongoing pandemic has only intensified the importance of good mental health for all individuals. I respectfully make 2 specific requests. Please reach out to your colleagues at the state level and implore them to maintain, better yet, to improve funding for mental health services in Philadelphia. And please consider city-specific funding and support for mental health providers. For nearly 50 years, PHMC has been a safety net for the populations we serve across our city and region. We are committed to continuing this work. We will continue to advocate on their behalf and work in collaboration with our funders, partners, elected officials to shine a light on the impact these budget decisions have on individuals, families, and communities we serve. Thank you again for the opportunity to speak with all of you today. I look forward to our continued partnership in improving the lives of the people of Philadelphia. Thank you.
Thank you for your testimony. I want to note for the record that Councilmember Alan Dom is also here, and also Councilmember Catherine Gilmore Richardson was here earlier, and we look forward for her hopefully being able to return back to this hearing. I have a couple of questions I would like to ask, and if any other members of council have questions, feel free to make reference to that or indicate that in the chat feature. First question is for Ms. Brummins. Can you give a perspective of the Alliance? You are a trade association of organizations that are providing services in this space. For many organizations, they have very tight budgets, and I want to get a sense of the average size of the organization that's a part of the Alliance, and what's their annual budget?
That's a good question. One that I don't know I'm prepared to answer, although right this moment, but I can get an answer for you. I would say we do run the gamut. We have very small organizations that have less than $1 million budget, and other organizations that have $200-300 million budgets. I would say that we are always concerned about the little guy in terms of, times like this, there may be less cash on hand, fewer resources. But I also think the flip side to that is that our providers who are larger, there's a lot more at stake. There's more, because we're not just thinking about the provision of services in isolation. We're thinking about the unspoken contract that you will have an employee who you're paying, right, to show up to work and come and do that work, who is going to serve someone who is in need of those services. And so when a larger organization has to lay people off in a bigger way, that's more people who are now without jobs. What then ends up happening is that people start to struggle with things like poverty, mental health issues as well. So I'm not sure if that's why you were asking the question, and I can certainly get you an answer.
Well, I just wanted to kind of give, for members of the committee and those watching, a kind of flavor of the nature of organizations that are part of the Alliance. Yes. But I'll ask this follow-up question, and I try not to make assumptions. What is the vast majority of the organizations that are part of the Alliance nonprofit organizations who receive the significant amount of the resources that they use to deliver services from federal, state, and local governments?
Correct. So the large majority of our organizations that provide direct services are nonprofit. And the caveat is that there's a category called associate members, and those would be the people who augment the work that we're doing. So benefits providers, accountants, attorneys, things like that. And so you, generally speaking, you can make an assumption that they are for profit. But in terms of the provider organizations, yes, they are mostly nonprofit. To be clear, the Alliance of Community Service Providers is not the only trade association in the city of Philadelphia. We are the largest, but we don't, our work, and, you know, when I quoted statistics to you earlier this morning, they are around alliance providers. And so just to, you know, really highlight the point that the problem is even worse than what I said this morning, because there are other providers that don't belong to the Alliance of Community Service Providers. Also, one more thing I just want to say is, you know, we were asked to come here today to talk about behavioral health, and I touched on ID a little bit, but for the people who are here today who don't understand the funding, our ID providers that money comes through the state directly, and so the issue for ID providers has been really, really difficult because day programs have all but ceased to exist. Funding was not there in the same way that the APA provided for behavioral health. So it's even compounded.
And thank you for that. And I just want to, because not everyone knows all of the acronyms. So when you say ID, you're talking about intellectual disability. In this space, and having been a member of a lot of different nonprofit boards, having served as a staffer in City Council, to former council member Marion Tasco, who chaired the Public Health and Human Services Committee, and also based my own experience with a son on the autism spectrum, I've got to know the various acronyms quite well. But for the services that are coming to the city from the Commonwealth for the Department of Behavioral Health and Intellectual Disabilities, the acronym is DBHIDS, and they also provide contract services to organizations like CBH or Community Behavioral Health. And there's a whole host of acronyms, but for the most part, the dollars we're talking about that we have concerns are the dollars that are coming for behavioral health issues, intellectual disability or ID, as well as substance abuse issues. Those are the bulk of the services and dollars that we're talking about with the various nonprofits, organizations that are reflected on this call. And when you talk about other trade organizations, I just want to state for the record that Asher Kemp, who is the executive director of the Coalition of Culturally Competent Community Providers, was not able to be here today, and that's an organization made up of predominantly African-American and other ethnic group-led providers in this space as well. And some of those organizations are also part of this network and part of some of the other organizations, or work with some of the other organizations that are on this call. Ms. Brummins, you had given us 4 questions for City Council, and I think those questions are part of the reasons that prompted me to have this hearing, because historically, and I said this in my opening comments, historically what has happened at a local level from a budgeting perspective, and a lot of time and energy is spent on the general fund dollars, and those are dollars that come to the city by way of resident and non-resident wage taxes, the business income receipt tax, real estate tax or real estate transfer tax, a sales tax or amusement tax. And a lot of that energy in our budget conversation is spent on those areas that come into our general fund. But as Dr. Bowen talked about, we receive a significant amount of money, and she just made reference to her area. We also have the health department as well, receive significant dollars at the federal and state level that also come into the city of Philadelphia. And those issues are not addressed as much. And that's why I wanted to have this conversation, because if we receive significant cuts at the state level, that will dramatically impact the organizations represented here and the constituents that we serve as members of council, not only from services, but also from employment, as well as other economic impacts. So just once again, for the record, if you could just restate those questions again that you stated in your testimony.
Yes, and I think you said 4, but it was 2. If I misheard that, I apologize. But So okay, the questions were, will providers of essential services be given the assistance that they need to account for additional expenses and lost revenue related to COVID? And just as some background, the catalyst for that question, other than there's a real need, is that we haven't heard anything about where the funds, the COVID money that was given to the city is going. And I think providers have been doing their best to provide a trail for what those costs were, but it's as though that conversation just sort of went away, and we don't know why or where some of that money is. So, and then the other question is, will you fight for us at Harrisburg, and how will City Council help us if the state drastically cuts funding? And I just want to say one more thing around our demographics in terms of our providers. So there are a lot of providers out there that provide both ID and autism services and behavioral health, and so. For them, and depending on the size, that could be a double whammy in terms of blows to the financial health of an organization. So, and as it turns out, too, for those of you who don't know as well, that it is often, or it's often the case that individuals are dually diagnosed, and they may have co-occurring drug and alcohol and behavioral health, as well as co-occurring behavioral health and intellectual disabilities and autism. So. It's complicated, and it's not two clear paths that are parallel. They often intersect. So,
thank you. And also, I just want to state as well, thank you for your advocacy regarding direct service professionals. In fact, just earlier today, I saw an email from ASME District Council 1199C doing a work with Philadelphia Works to try to hire and get more people into the DSP or direct service professional area. That is a great need, especially need to increase their salaries. Even when we were in a more robust economy prior to COVID, that has been a historical concern because of the turnover and not being able to get the salaries that those service professionals need, who provide such a critical infrastructure for the communities that are represented and serviced by the organizations in this panel. I can relate to that directly based on the services that my son has received and so many families around the city. So I want to thank you for your advocacy in that regard and trying to increase those salaries. I have a question for Dr. Adrienne Torres O'Connor. And you touched on this in your testimony, I want to get some more perspective on the issues of mental health and the homelessness issue we've had in our city. We've had, you made reference to a number of statistics and information that the pandemic has started to increase those issues. And I know your organization's been doing a lot of work in a number of areas. I know we've had direct conversations regarding your advocacy and support for the increase of homeless individuals that were at the airport and trying to resolve that issue, working with Delaware County and your organization providing services for people who are homeless. But if you can give some more perspective on how COVID and a possible loss of state dollars could impact and increase this concern in our city. This has been, I think, heightened by both the encampment on Ben Franklin Parkway, as well as adjacent to Philadelphia Housing Authority. But I think if there's an additional cut in resources, this is going to be a more challenging issue for our city.
Thank you. So yes, in terms of the homeless, our homeless services and what we have been seeing and in the trends, because of COVID-19, and the subsequent job losses throughout the city, the number of people who are experiencing homelessness has gone up because of that. And we're seeing a lot more women and families. In addition, what's compounding the issue is the shelters are full. They're full. They cannot take any more individuals. There are more individuals who are in need. And in addition, because of the safety precautions from the CDC and our own health department regarding 6 feet spacing, there are more people in need. The shelters are full, and the shelters, because they have to increase people's safety, they have to space people. So then there's less room on top of that. So it really is an ongoing compounding factor. And Dr. Bowen also indicated that inpatient facilities are also experiencing an increase in admissions. And that can also be contributed to individuals who are recently in the homeless experience, because they've lost their jobs, they've lost their insurance, they've lost their ability to take the psychiatric medication that has helped to support their mental health recovery. So there is a lot of decompensation that my staff is experiencing, a lot more crises that my outreach teams are intervening with. So this is really having a trickle effect that Sarah, Malcolm, and Sherry have also highlighted in terms of where we are with the homeless populations. And I don't feel that the answer is more shelters. I think we need to come up with a systemic kind of short, medium, and long-term solutions. I think that's possible, but that is going to take funding as well.
Thank you for that response. And, when we think about this pandemic, we don't think of all of the detailed impact it has had on so many aspects of our entire ecosystem. So you just kind of highlight an area that I had not really thought about until you made your comments. Historically, we've had challenges in not having enough space in facilities that provide services for people who unfortunately may be homeless. But when you add a virus, and now you're talking about having those facilities in a more compromised perspective because they're indoors, and you're trying to protect people from the transmission of a virus, that's going to create some additional challenges for services for people who are homeless. And then when you think about how in our retail establishments like restaurants who are not able to be at 100% capacity, but at a much reduced capacity because they cannot have as many people in that location in order to provide a meal, and not having bars open and having stools and people be able to drink at a bar. When you make that same connection on a location providing services for those that are homeless, they're also going to have to deal with reduced capacity because of the virus. So that's going to even reduce what was already a not enough capacity for those who are homeless, an even greater level. And that I want to thank you for that point, because I had not really thought about it in that context, in that perspective. You also said and made point to we've got to think beyond just a shelter system and think about other aspects. Some have heard me use this analogy in other hearings when I've been talking about how the pandemic has impacted us in a number of ways. I've heard various entities and organizations that have looked at this issue and compared the pandemic from a 5R approach, one being resolve, resilience, return, reimagination, and reform. And the analogy I use is that resolve is imagine if you're walking down Broad Street and you tripped and fell, and all your papers and your books and your things you had on you were scattered all over. And that's how the pandemic hit us. Like all of a sudden in March, we got slammed with this issue that just kind of knocked us off our feet. And so just like it took us some time to kind of get our perspective on how we deal with this virus, that's similar if you were to trip and fall on Broad Street at 12 o'clock in the afternoon. And so the resolve is the first step of, okay, this just happened. Let me get an understanding of where my papers are, where my notes. Did I scuff my pump? Did I scuff my shoes? And just got a sense of what happened. That next step is resilience. Resilience is that, you understand what just happened, which is similar to what happened in COVID. And now we're trying to get some perspective of how do we get back up. Similar to if you tripped on Broad Street, resilience is like, okay, I got to get back up. And now I got a sense of what just happened. The return is, okay, how do I get myself to where I was before I tripped on Broad Street? That's the same thing that's happening with us with COVID. How do we get back to where we were before COVID struck in March? But those last two parts of this 5R approach are reimagination and reform. How do we see to do things differently and using this kind of situation of COVID to get us to reform the way we provide services and do things? And so when you talked about beyond just the shelter approach, can you give a little perspective on how we would reimagine and reform how we provide homeless services, especially when we may have some reductions at the state level and may have to do things differently in a different perspective because of that?
So, we at Mental Health Partnerships, we've been discussing this actively. And I think in terms of broadening the scope, I think a public-private partnership really needs to happen because, and when I mean public, I'm not talking necessarily governmental, but for-profit organizations, other industries, finance, housing, real estate, to really put together for a long-term vision how they can contribute, because as some of my colleagues on the panel have stated, and Dr. Bowen did as well, it solving and supporting and recovering from mental health issues is a multi-systemic approach. It's not just the responsibility of social service and healthcare. People are impacted when they've lost jobs in the food service industry, at the airport. It is a trickle-down effect. Being able to just kind of walk past somebody who's experiencing homelessness, outside of the industry that is social services, human services, or behavioral health, and saying it's not my problem, it is, because that person very well could have worked in your industry. I can't tell you in my 20-year career how many individuals who worked in white-collar classified jobs were now coming to my organization for homeless services. It is not a far fall for people who are in the for-profit or commercial industries. So I think starting to have those conversations is really going to be pivotal to be able to help solve and support a successful solution to the experience of homelessness, because housing is a right. Safe, affordable housing is a right. It is not a privilege. And it is a right that everybody should be entitled to.
Thank you, Dr. Torres O'Connor, for your comments. I want to also note that Councilmember Isiah Thomas is also here and present for this hearing. Any members of council have any questions, please indicate that in the chat feature. I have questions for Mr. Musgrove and Ms. Melina Robinson from Marquis and PHMC. Both of your organizations have a wealth of relationships and connections and staff, and I'm curious what you may have seen in maybe other jurisdictions on some of the issues that they're dealing with regarding these concerns, maybe outside of the city of Philadelphia, and how they're dealing with some of these potential challenges, and some additional input that you can provide in that regard.
I think the challenges that we're facing here in Philadelphia are challenges that we're facing across the state of Pennsylvania. The pandemic is, in some cases, has reduced access to treatment. Not only seeing that in Philadelphia, but seeing it in our surrounding counties, Montgomery, Bucks, Delaware, and Chester. we're grateful that all of the MCOs have managed to put in place an APA that is helping us stay afloat. But we
sorry to interrupt. If you could just define APA for those who may not be familiar with that acronym.
And it's an alternative payment arrangement. So we're not billing fee for service. They're looking at our bills from a year ago, and they're matching what we billed a year ago, and they're paying us for those, paying us that way. Without that, I think that most agencies, whether you're small or large, would be in a world of trouble at this point. But we most certainly are fearful that in January that the APA will not be in place. Our volume is down. In some programs, our access is up, but our volume is down, and that's due to our consumers not having the ability to support audio, visual technology, and not having the ability to be on the phone for a session for an hour. So we've reduced that to 30 minutes and in some cases 15 minutes. But access to treatment is up. Which is a plus, and I think is a positive coming out, hopefully at some point when we come out of this pandemic, that we will have the ability to see consumers face-to-face and see consumers through telehealth, because I think it is a resource that most certainly will help the communities that we serve. It is really tough for, at times, for a parent who have multiple children to take their children to one child's appointment. And in many ways, the system has penalized them for not attending appointments. But I think through telehealth, we give them an opportunity to access treatment in a different way. So I do think that out of what has occurred in this pandemic, the access to telehealth most certainly will give us the ability to serve the communities that we are in a different way. But I do believe that the problems are not much different.
Yeah, and I want to kind of, Ms. Melina Robinson, if you want to add.
Yeah, I just wanted to add, we similarly have seen with our partners in the surrounding counties and the work that we do in Philadelphia, an increase in having to respond to families' needs. You know, there's an increased need for services, families need resources, and so our staff are working very hard to respond to all those needs. And at the same time, we're seeing the impact and responding to individuals that have behavioral health needs and didn't have behavioral health needs before, but the impact of the pandemic really is requiring more additional services. And so one of the things that we're really concerned about is we're looking at these budget implications is more supports and services specifically for our populations in the home, because what we're trying to do is families really want to support their family members at home and in the community. But if there's no services, if there's a lack of staff, then we're looking at increased hospitalizations and maybe residential placements. And we see the struggle with families having to make the decision about, I want to keep my family member at home, but I don't have the resources and the services to do that. And so now I'm thinking about residential care. So that's a lot of the dialogue that we're hearing and we're experiencing in our programs.
And if I could follow up with both of you regarding this point, I know in the beginning part of this pandemic, I was talking with a number of providers in this space about the challenges because of COVID, they could not provide the same type of care they had provided in the past, where they were coming into the home and providing services. And then based on a number of hours per week, then that direct service professional as part of their organization were being paid from various entities on that type of service unit delivery. But because people could not go into the home, they had to find alternative ways of providing services, and that led to an increase in telehealth, but also going back to what you both were talking about, an alternative payment arrangement. And so my understanding is that based on that alternative payment arrangement, your organizations and others were able to continue to receive payment for the services that you're providing, even though the services were not at the same level because you were not able to go into the home, but you were using telehealth. And so what I'm hearing is that not only are the cuts a potential challenge for your organizations, but if there are additional policy changes that revert back to where things were before, that's also going to reduce resources to your organizations as well. Am I correct in that understanding?
Yes.
That would be correct.
That would be correct.
Sarah, can I just add to one of the things that we're becoming more aware of?
If you can state your name for the record for the stenographer.
Sherry Brummins, my apologies. One of the things that we are aware of is that we had a very condensed period of time that we had to get up and running, right? And so one of my associate members put it this way: we're really living more like we're in 2025 right now when it comes to how we're doing things, especially when it comes to telehealth and the ways that we've just been able to sort of pivot on a dime. And I know it's not been that easy, but you know, when you look at a time frame that it would have taken us to get to where we are right now, it happened pretty quickly. And so when you talk about policy changes, one of the things that we're very concerned about is, you know, we can't go backwards in terms of that. We may pull back some of the telehealth because I think, you know, obviously it's great to be in each other's presence and sense of community. But, you know, to Malcolm's point, there are people for whom getting to doctor's appointments were an issue way before COVID happened. And so I would just want to say that we are advocating for things to not be pulled back after after COVID in a way that kind of puts us back 10 years. So.
Does anyone else want to chime in? I thought some others were chiming in on that question as well.
This is Dr. Adriana Torres O'Connor. I just want to kind of add, Malcolm had said that they're experiencing a decline in their participation. So from behavioral health standpoint, traditionally, there is an approximate 25% drop-off rate that traditionally happens and can be expected when services move from in-person to telehealth. So I know that at Mental Health Partnerships, our drop-off followed that traditional trend, which happens, which I believe Malcolm was referring to. But for us, it has recently increased further to closer to 30% because the free minutes that were originally offered by a lot of these phone companies have stopped, and our participants don't have the funds to pay for minutes. There is provider fatigue, which Malcolm alluded to. A normal session would have been 45 or 60 minutes. And if you're supposed to see or check in with 3 different providers in a day, not only do you not want to be on the phone for 3 hours, I mean, I don't want to do that. I can't imagine what our participants wanting to do that when they have all these other demands, but they also have limited minutes. And then you've also experienced the drop off of people where telehealth is just not a fit. It was hard enough to engage in person, and now suddenly you're disconnecting them from human interrelatedness, and it's just not going to work. Thank you.
Thank you for your comments. If any other members of council have any questions or would like to ask a question, please indicate that in the chat feature. I think it's been so interesting, this whole conversation. When you make reference to telehealth, for some of the people that work in this body know that my wife has worked in healthcare for a number of years from an information technology standpoint. Telehealth has been something that's been coming for a long time. Some entities have been able to use it, but a lot have kind of continued to say, we'll get to it when we'll get to it. And so there's been a slow adoption for telehealth in a lot of ways. However, this pandemic caused the adoption to happen now. And I think because of that, has made some changes and disruptions in how services are provided, but it also provides some opportunities for especially those in this area who were, because of mobility issues and other challenges, were not able to get access to all the services they need. So I definitely agree with the commentary of how we can take some of the lessons learned from this unfortunate pandemic and continue to use these lessons as well as other ideas and suggestions to do the best that we can to provide services for those that need these services based on the funding that comes to the city. With that, I don't see any additional questions or comments from members of this committee. I want to thank, and there's also make one last statement. Are there any members of the public that are here that would like to testify? Seeing none, I want to thank all of you for being here for this hearing. I want to also thank that any additional advocacy that you would need from this body, especially in reference to the issue that was brought forth today regarding concerns of cuts at the state level, let us know. Definitely be willing to work and advocate in the Commonwealth on the challenges we need to make in reference to those issues. And we stand ready because we know that if those cuts were to occur, we will have some significant challenges here in the city of Philadelphia based on all of the things that has been identified this morning. So with that, I want to thank you all, especially my colleagues, for listening and being here and asking questions for this hearing. And seeing no other additional comments or perspectives at this point, this concludes the public hearing of this committee of people with disabilities and special needs. We will recess this hearing until the call of the chair. I want to thank all of you for your participation and information this morning. It was very informative, and thanks again, and we look forward from hearing you on how we can do the best that we can to address this issue for our constituents going forward. Thank you and take care.
Yeah.
Thank you.